Good morning, everybody. I'm thankful to the organizers giving me opportunity to talk about review of Myasthenia Gravis during this session of second Dhabi Neurology Hybrid Congress. With reference to disclosure, I have nothing to disclose about this presentation. What are the objectives of the talks? The objectives of talks is to discuss the epidemiology, clinical presentation, pathogenesis, diagnostic tests, treatment options, and prognosis. As you know, the Myasthenia gravis is the most common neuromuscular junction disorder, is most well studied, also autoimmune neuromuscular disorder too. With reference to epidemiology, the incidence rate and the prevalence rate has been variably reported in multiple studies in last 6 or 7 decades, with the non-linear increase in both incidence and prevalence rates. And in the studies were mostly done in the Europe and North America, and the most increase in incidence and prevalence rate happened in 1980s. That's part because of increased awareness about the disease, better serological testing, and also better methods of epidemiological studies, along with the immunosuppressive therapy and intensive care support for the patient with myasthenic crisis. The incidence report rate at this point is 5 to 30% per million person years. Prevalence is estimated between 10 to 20 cases per 100,000 of the population by model age distribution, and the incidence of myasthenia gravis with a peak around the age of 30 and 50. In early peak of 30, the female is predominantly involved with 7 to 2 ratios, and the late peak, the male with the ratio of 3 to 2. There is a juvenile myasthenia that starts before the age of 18, that makes about 10% of total myasthenic population, that mostly seen in East Asia. What about the clinical presentation? With reference to clinical presentation, the hallmarks is a fatigability, fluctuating muscle weakness that involves the ocular muscles in the form of ptosis, binocular diplopia most common, followed by generalized weakness, bulbar muscle weakness, respiratory muscle weakness, and myasthenic crisis. There is some atypical presentation that mostly happens in the patients who are MuSK antibody positive. They have a more neck extension weakness than the flexion, shoulder abduction, respiratory muscle weakness, and oculobulbar weakness more prominent than the generalized weakness. Fixed facial muscle weakness, weakness of the tongue and pharyngeal muscles, those are poorly responsive to the response to the treatment. With reference to pathogenesis of myasthenia gravis, is antibody-mediated T-cell dependent immunological attack on the postsynaptic membrane, results in the damage of the postsynaptic muscle membrane. Antibodies against the acetylcholine receptors that binds to the main immunogenic region of the alpha subunit of acetylcholine receptors is the most common antibody and cause destruction of postsynaptic end plate region through complement activation. MuSK plays an important role in clustering of acetylcholine receptors and the end plate region and in the end plate formation and maintenance, but the role of anti-MuSK antibodies in the pathogenesis of myasthenia gravis is not fully understood. Antibody production in myasthenia gravis is T-cell dependent, and the thymus plays an important role in the dysregulation of the self-tolerance. With reference to the diagnosis of myasthenia gravis, that's diagnosed based on the clinical presentation, neurological exam, and diagnostic tests. Clinicians mostly make the diagnosis with the clinical history and neurological test exam, and they confirm their diagnosis based on the further diagnostic tests. Clinical tests that we use mostly in the clinic is the iSpec test, Cogan-Lit twitch test. Pharmacological test includes edrophonium test, is called Alcon, previously used to be Tensilon test. Antibody testing includes acetylcholine receptor antibodies that includes binding, blocking, and modulating. Binding is the most common one. In generalized myasthenia gravis is about 85% and ocular about 50% positive. Anti-MuSK is about 40 to 70% in seronegative acetylcholine receptor patients. There are other antibodies that also have seen associated with myasthenia gravis. That's antibodies against myosin, actin, alpha-actin, titin, anti-titin, and ryanodine receptors, commonly associated with thymoma in 94% cases. Anti-titin and ryanodine antibodies, more severe disease presenting after 40 years. LRP antibodies are about 9 to 9.2%. What about the electrophysiological testing? The repetitive nerve stimulation, the classic electrophysiological demonstration of a neuromuscular transmission defect, is the documentation of decrement response of compound muscle action potential to a slow 2 to 3 Hertz motor repetitive nerve stimulation. A decrement of greater than 10% is considered a positive repetitive nerve stimulation study. In generalized myasthenia gravis is in distal muscles, the sensitivity is less, about only 38% positive, but in proximal muscle is about 64%. In ocular myasthenia, decrement is at about 10 to 50% of the patients. Here are some examples. Initially, we do repetitive nerve stimulation at baseline. If you do see that there is a significant decrement that mostly seen with the CMAP from 1 to 4 or 1 to 5, we do post-exercise 10 seconds to see if there is any facilitation that make up the deficit. And if that's not positive, post 1 minute exercise after baseline getting the traces, and then we do at post 1 minute, 2 minute, and 4 minute or 5 minutes also, and see if there is any significant decrement. And then we also look for post exercise facilitations. With reference to single fiber EMG, single fiber EMG is basically check the jitter. The jitter value is the measurements of the variation of interpotential interval between the triggered potential and the time-locked second single muscle fiber potential. The extensor digitorum communis muscle is studied first, and if it's normal, a facial muscle like frontalis or orbicularis oculi should be also tested. Single fiber EMG, when performed in a weak muscle, is the most sensitive diagnostic test to confirm the neuromuscular transmission disorder like myasthenia gravis, about positive in 97% cases. By checking more weak muscles, the positivity rate goes up. I'm showing you to the two normal single fiber EMG and the first tracing, and then this abnormal single fiber EMG with showing a jitter and the second trace. With reference to the management of myasthenia gravis, there is a symptomatic treatment, acetylcholine inhibitors that was used. Physostigmine in 1934 was initially used by Walker, then prostagmine in 1930s to 1950s, no more available, but it is only available as IV neostigmine. The pyridostigmine that we used lately is a synthetic acetylcholine esterase inhibitor. Acetylcholine esterase inhibitors have a low response with anti-MuSK positive patients as compared to the acetylcholine receptor autoantibodies. Juvenile patients with myasthenia have particularly robust acetylcholine esterase inhibitor response. Ocular myasthenia, and particularly with the diplopia, frequently does not respond very well to the acetylcholine inhibitors, but ptosis does. Can be used in the long term, and the effectiveness does not go away. What about the immunosuppressive therapies? The corticosteroids is first widely used immunosuppressive therapy. Mechanism of action is unknown mostly, but a broad inhibitory effect on the immune response via the reduction of endothelial adhesions of leukocytes and decrease in inflammatory cytokine productions. Dramatic impact on myasthenic patient with 80% or more showing after medical remission of either medical remission or marked improvement. Initial benefit within 1 to 2 weeks. And maximum benefit can be seen in 6 months, and some may take about 2 years or more in other cases. There are two prevalent approaches for the oral corticosteroids. One is a high-dose rapid treatment induction regime, and the second is a low-dose slow titration to avoid the acute worsening of the existing weakness that can happen about 50% cases with the high dose. A third and more recent approach is based on the mycophenolate mofetil study, which starts a fixed dose of prednisone 20 milligram. The systemic side effects of the long-term corticosteroids are numerous and very impactful. The multiple retrospective studies have shown evidence that corticosteroid immunotherapy may reduce the risk of developing generalized myasthenia gravis from a patient with ocular myasthenia gravis. What about the other steroid-sparing agents? Azathioprine is the most common widely accepted steroid-sparing immunosuppressive medication used since 1970s. Azathioprine is a purine synthesis cytotoxic antimetabolite that inhibits DNA and RNA synthesis, cellular replication, and lymphocyte function. In comparison with other steroid-sparing options, azathioprine has more favorable tolerability, although a major challenge in its use is the estimated 6 to 8 months latency. A number of earlier retrospective studies have suggested that the success rate for azathioprine ranged from 70 to 91%. Mycophenolate mofetil is the second most commonly at present time is used as a steroid-sparing agent. It inhibits glycine nucleotide synthesis that is essential for B and T lymphocytes. Several retrospective studies suggested a favorable tolerability profile, the potential for a prednisone-sparing effect, and the robust rate of disease control around 70. In comparison with azathioprine, a more rapid initial clinical response seen within 11 weeks is contraindicated in pregnancy owing to the teratogenic potential and possibility of miscarriage in the first 3 months. There are other medications that has been used previously, but lately they are used in case reports only. The cyclosporin, tacrolimus, methotrexate, and cyclophosphomides. What about the newer medication that includes the Rituximab? Is a genetically engineered chimeric mouse human monoclonal antibody directed against CD20, a transmembrane protein selectively found on the surface of normal and malignant B lymphocytes. Rituximab decreased the number of circulating CD1 B cells and is also thought to suppress the antibody production and humoral immunity. A recent systemic review of the available retrospective rituximab studies found that the MGFA post-intervention scale of minimal manifestation or better was attained in about 72% of MuSK patients and 30% of acetylcholine receptor antibodies patients. Strongest predictor for clinical response is positive MuSK antibodies status, less severe case, and younger age at the time of the treatment. With reference to eculizumab is a recombinant humanized monoclonal antibody that binds to the C5 complement protein and inhibits its subsequent cleavage and formation of C5b-9 membrane attack complex. Approved in late 2070s for the treatment of adult patients with generalized myasthenia gravis who are acetylcholine receptor antibodies positive after successful trials. Indication for eculizumab are those in the moderate to severe status category despite receiving adequate trials of most, if not all, immunosuppressive medications. And there's certain regime we use for induction therapy and then the maintenance. Eculizumab requires a meningococcal vaccination before starting the therapy. If that's not possible, then it requires a prophylactic antibiotic until vaccination has been completed. With reference to F-Gati-Gmod, it's a new human immunoglobulin G1 antibody Fc fragment engineered to reduce the pathogenesis of immunoglobulin G autoantibody in 2018-2019 randomized clinical trial that includes 167 patients and 77 boards were acetylcholine receptor antibodies positive. Myasthenia gravis ADL responders were 68% in cycle 1, then in the placebo group was only 30%. What about the therapeutic plasma exchange? Therapeutic plasma exchange has gained wide acceptance as an effective treatment in patients with myasthenia gravis since initial reports in late 1970s. Plasma exchange mechanism of action is through the removal of plasma soluble factors including pathogenic autoantibodies and cytokines. Indication for short-term course of plasma exchange include myasthenic crisis in myasthenia gravis grade 5 on mechanical ventilation, impending crisis in patient with severe myasthenia gravis grade 4B or 4 with dysphagia, respiratory functional, generalized weakness, and when patient with the mild 2B, 2 or 3 and 3B with myasthenia gravis is worsening or not responding to other immunosuppressive therapies. Pre-thymectomy in symptomatic patient to treat the respiratory and pharyngeal muscle weakness before the surgery. What about the intravenous immunoglobulin? Interferes with the co-stimulatory molecule, suppresses antibody production, hinders complement activation and MAC formation, and modulates the expression of FC receptors on the macrophages and diminishes chemokines, cytokine, and adhesion molecules. The indication for the use of IVIG in myasthenia gravis are identical as with plasma exchange. A variety of complications have been reported with the IVIG neuromuscular disease, but most of them are mild to moderate in severity. Mostly induction dose is about 2 grams per kilogram and 2 to 5 divided doses. What about the surgical treatment? In thymoma patients, the tumor should be removed. Tumor histological grade, excision margins, and the distal spread guides treatment decision to subsequent radiation, chemotherapy, or monitoring. In non-thymomatous generalized myasthenia gravis, thymectomy has become the standard despite a lack of evidence from a good prospective clinical trials. That led to a recently completed landmark international randomized rater blinded clinical trial was completed to address this uncertainty. Positive effects of thymectomy are seen in as early as 3 to 4 months and were maintained for the entire 3 years study. During the study, it was seen that KOMG score was significantly lower in patients with thymectomy plus steroids as compared to only steroids. The dose required for the steroids was much lower, 32 milligram as compared when the thymectomy patient as compared to the steroids only group that required about 54 milligram. There has been a quite improvement in thymectomy patients in the myasthenia gravis status, other complications including myasthenic crisis. What about the prognosis of myasthenia gravis? The current mortality rate in myasthenia gravis is reported as 0.06 to 0.89 deaths per million person a year. Between 1940 to 1957, the mortality rate was 31%, and from 1960 to 1985 was 7%. There are two primary reasons for this reduced mortality rate: the improvement in intensive care, intensive respiratory care, and the introduction of immunosuppressive treatments. There are approximately 10 to 20% of patients experience a complete or near complete remission for at least 6 months. Most patients have one remission, but as many as 5% may have 2 to 4 remissions. The average interval between disease onset and remission is about 4 years. Remission is more common in juvenile and female myasthenic patients. What's the conclusion? Conclusion is myasthenia gravis is highly treatable neuromuscular autoimmune disease that needs to be properly diagnosed and managed. Myasthenic crisis is a neurological emergency with a good prognosis and a low mortality when properly diagnosed and treated with plasma exchange and IVIG and intensive support care. Many immunomodulating drugs are currently in preclinical and clinical trial development, and the treatment options available for patients with myasthenia gravis continue to improve. There are some unresolved issues remains when and how to discontinue immunosuppressive therapy to patients and have patients who have achieved the remission, and which patients are at higher risk of relapsing. The role of early prednisolone use in the purely ocular myasthenia gravis in preventing the generalization, and the role of thymectomy in anti-MuSK seronegative and childhood myasthenia gravis. With this slide, I'm going to end. I have some references here on the next slide, and I appreciate all of your attention, and thank you very much.